Okay, streaming now.
Okay.
Good morning, sir.
Good morning.
Good
Morning, sir. Arvind.
Mohan Kumar, sir. Arvind, good morning. Rajalakshmi join cheyala, sir.
Rajalakshmi join cheyannu varunnu. Enna vilchoka. Arvind.
Good morning. Good morning.
Mohan Kumar, sir. Arvind, good morning.
Manju ഒന്ന് രാജലക്ഷ്മിനെ വിളിക്കുവോ?
വിളിക്കാം സാർ. എന്റെ ഈ സൗണ്ട് കറക്റ്റ് ആയിട്ട് കേൾക്കുക. കുറച്ചൊരു കണക്ടിവിറ്റി ഇഷ്യൂ ഉണ്ട്. കേൾക്കുന്നുണ്ടോ കറക്റ്റ് ആയിട്ട്?
എനിക്ക് ക്ലിയർ ആണ്.
ഞാൻ വിളിക്കാം സാർ, വിളിക്കാം.
ചെറിയൻ
എന്തോ പറ.
അല്ല, ഓപ്പണിംഗ് ചെയ്ത സമയത്ത് ആഫ്റ്റർ ദാറ്റ് ഐ വിൽ ബി കോളിംഗ് യു ഫോർ പ്രസിഡൻഷ്യൽ അഡ്രസ്. അടുത്ത സ്ക്രീൻ. ഓക്കെ. അതിനുശേഷം ഞാൻ മഞ്ജുനെ ഒന്ന് ബ്രീഫായിട്ട് ഇൻട്രൊഡ്യൂസ് ചെയ്ത ശേഷം ഹാൻഡ് ഓവർ ദ പ്രൊസീഡിംഗ് ടു മഞ്ജു ആൻഡ് ദെൻ മഞ്ജു ടേക്ക് ഓവർ. അല്ല, ഓപ്പണിംഗ് ചെയ്ത സമയത്ത് ആഫ്റ്റർ ദാറ്റ് ഐ വിൽ ബി കോളിംഗ് യു ഫോർ പ്രസിഡൻഷ്യൽ അഡ്രസ്. അടുത്ത സ്ക്രീൻ. ഓക്കെ. അതിനുശേഷം ഞാൻ മഞ്ജുനെ ഒന്ന് ബ്രീഫായിട്ട് ഇൻട്രൊഡ്യൂസ് ചെയ്ത ശേഷം ഹാൻഡ് ഓവർ ദ പ്രൊസീഡിംഗ് ടു മഞ്ജു ആൻഡ് ദെൻ മഞ്ജു ടേക്ക് ഓവർ. ഓപ്പണിംഗ് ചെയ്ത സമയത്ത് ചെറിയ എനിക്ക് തോന്നുന്നു നമ്മുടെ ലൈവ് സ്ട്രീമിംഗ് ഇതിനകത്തോട്ട് കയറി വരുന്നുണ്ടെന്ന് തോന്നുന്നു, ഡിലേ ആയിട്ട്.
സാർ എന്താ റിപ്പീറ്റ് ആയിട്ട് കേൾക്കുന്നത്? പിന്നെയും
റിപ്പീറ്റ് ആയിട്ട് കേൾക്കുന്നത് നമ്മുടെ ലൈവ് സ്ട്രീമിംഗും ഇതിന്റെ കൂടെ കയറി വരുന്നുണ്ടെന്ന് തോന്നുന്നു ചെറിയന്റെ സ്ക്രീനിൽ നിന്ന്.
പക്ഷെ നമ്മൾ പ്രോഗ്രാം നടക്കുമ്പം കുഴപ്പമുണ്ടാവില്ല അല്ലേ?
ഇപ്പൊ നോക്കിയോ?
ചെറിയൻ സാർ ഉണ്ടോ? ഗുഡ് മോർണിംഗ്.
ഇപ്പം കേൾക്കുന്നില്ല.
ഇപ്പൊ ഇല്ലല്ലോ.
ഇല്ല.
അത് ഞാനേ ഇവിടെ നിന്ന് മ്യൂട്ട് ചെയ്തു, അതുകൊണ്ട്.
നമ്മുടെ ലൈവ് സ്ട്രീമിംഗ് ഒരു ഇച്ചിരി ഡിലേ ആയിട്ടായിരിക്കും വരുന്നത് മഞ്ജു. അതിന്റെ വോയിസ് ആണ് കയറി വന്നത്.
ആ യൂട്യൂബ് ലൈവിന്റെ ഓഡിയോ കയറി വന്നത്. മ്യൂട്ട്.
അപ്പൊ എല്ലാവരും നമ്മുടെ ഇതിന്റെ അകത്തെല്ലാം സ്ട്രീമിംഗ് ലൈവ് എന്ന് പറഞ്ഞൊരു മെസ്സേജ് ഒക്കെ അയച്ചേക്കാം കേട്ടോ, ആൾക്കാർ കയറിക്കോട്ടെ. എനിക്കൊന്ന്
ഓക്കെ.
Good morning, Rupesh sir.
Morning. Srijit, good morning.
Good morning. Hello, good morning. കേൾക്കുന്നുണ്ടോ?
കേൾക്കാം.
ഓ ഓക്കെ ഫൈൻ.
Audible.
Yeah, okay fine. 10:45 അല്ലേ?
അതെ 11. ശ്രീജിത്ത് PGസിന് മെസ്സേജ് അയച്ചിട്ടുണ്ടല്ലോ അല്ലേ?
ഇല്ല, ഓൾറെഡി അയച്ചതാ.
ഓക്കെ.
ഇപ്പൊ ജോയിൻ ചെയ്യും.
നമ്മുടെ സ്പീക്കറിന് എന്തോ ജോയിൻ ചെയ്യാൻ പറ്റുന്നില്ല എന്ന് പറയുന്നത്.
എനിക്കൊന്ന് നാളെ എക്സാം ആയതുകൊണ്ട് ചിലപ്പോ എക്സാം വർക്കിലായിരിക്കും.
ഓക്കെ. അല്ല, കുറെ പേര് ജോയിൻ ചെയ്തിട്ടുണ്ടല്ലോ. അല്ല IPSK caps lock IPSK. Sure. Dr. Cherian, Dr. Rajalakshmi, if she is joined, if we can make her a co-host, maybe we can try the slide sharing. Rajalakshmi, if you have joined, kindly respond.
സർ, രാജലക്ഷ്മിക്ക് എന്തോ പാസ്പോർട്ട് കറക്റ്റ് ആവുന്നില്ലെന്നാ പറയുന്നത് ജോയിൻ ചെയ്യാൻ.
ഞാനിപ്പം രണ്ടാമത് സംസാരിച്ചല്ലോ രാജലക്ഷ്മിയുടെ. IPSK capital.
മഞ്ജു കേൾക്കാമോ? മഞ്ജു
Sir, Mohan Kumar sir, good morning.
രാജി
കൺഗ്രാറ്റുലേഷൻസ്. പ്രൊഫസർ ആയാലും പ്രസിഡന്റ് ഹെഡ് ആയാലും ഞാൻ
Thank you, sir. Clear alla sir. Thank you so much.
ഒന്ന് റീബൂട്ട് ചെയ്ത്
Sir,
നോക്കി.
video on ചെയ്തോ? ഇല്ല, video off ആണ് sir.
മനസ്സിലായി. അങ്ങനെ ഓഫ് ഒരച്ച് മുങ്ങണമെന്ന് തോന്നിയാൽ മുങ്ങാണ്ട് എനിക്ക് ആരും കാണില്ല.
സാറിന്റെ വീഡിയോ ഓഫാ.
മനസ്സിലായി. അത് ഓഫാക്കിയിരിക്കുക. ഇടയ്ക്കൊന്ന് മുങ്ങണമെന്ന് തോന്നിയാൽ മുങ്ങാനോ.
ഓക്കെ ക്ലിയർ അല്ല സർ.
ശരി, ഓൺ ചെയ്തു നോക്കിക്കോ.
സാർ ഇപ്പഴും റീബേസ്ഡ് ഇരിക്കുന്നേ ഉള്ളൂ അല്ലെ?
പഴയ ശരിയാ, അത് റീബേസ് ആണ് ബാക്കി കാണുന്നത്. ഓർക്കുന്നില്ല. ഇപ്പൊ റീലൈൻ ചെയ്യാ. എന്താ ഇദ്ദേഹം മലയാളി ഈ സ്പീക്കർ മലയാളി ഇല്ല. എന്തോ അത് ഡയറക്റ്റ് ചെയ്ത് നോക്കട്ടെ. ഈ സ്പീക്കറെ മലയാളിയാണോ ഇവിടുത്തെ?
ഷീ ഈസ് ബേസിക്കലി ഫ്രം കേരള, പിന്നെ ബോൺ ആൻഡ് ബ്രോട്ട് അപ്പ് അറ്റ് നാഗ്പൂർ.
അതാണ് ബാനർജി എന്ന് കിടക്കുന്നോണ്ട് ചോദിച്ചത്.
PG കൺവെൻഷൻ CMEs കണ്ടക്ട് ചെയ്തിട്ടുണ്ട് ആള്.
അത് ശരി. ഞാൻ
നമ്മുടെ നാഗ്പൂർ കോൺഫറൻസിന്റെ ഓർഗനൈസിംഗ് സെക്രട്ടറി ആയിരുന്നല്ലോ. നാഗ്പൂർ കോൺഫറൻസിന്റെ സയന്റിഫിക് ചെയർ ആയിരുന്നു.
അത് ശരി. അത് വന്നില്ല, നാഗ്പൂരിൽ പോയില്ല.
ഓൺലൈൻ ആയിരുന്നല്ലോ സാറേ.
അതുകൊണ്ട് ചേർന്നില്ല ഞാൻ. എവിടെ നിന്ന് സംസാരിക്കുന്നു ഇപ്പൊ? എവിടെ ഇരിക്കുന്നവര്? നാഗ്പൂരിൽ ഇരിക്കുക. എവിടെ ഇപ്പൊ അവര്?
PSPM നാഗ്പൂർ കോളേജില്.
രാജലക്ഷ്മിക്ക് മാത്രം ലോഗിൻ ചെയ്യാൻ പറ്റാത്ത എന്താ മനസ്സിലാവുന്നില്ല.
അതെ
സ്പീക്കറിന് മാത്രം. അതെ,
രാജലക്ഷ്മി നേരത്തെ ലോഗിൻ ചെയ്ത് ട്രൈ ചെയ്ത് നോക്കിയതാണ് പോലും. പിന്നെ ഇപ്പൊ രണ്ടാമത് ട്രൈ ചെയ്യുമ്പോൾ പറ്റുന്നില്ല പറഞ്ഞു.
ഓക്കെ
തന്നെ.
Good morning.
Good morning.
Good morning, ma'am.
Good morning, Raji.
Ma'am, ശബ്ദം കേൾക്കാമോ അതോ?
Yeah, we can hear you. ഒരു കുഴപ്പമില്ല.
കേൾക്കാമോ? കാര്യം കണ്ടിട്ട് ഭയങ്കര സന്തോഷം. കുറെ നാള് കഴിഞ്ഞാൽ.
Actually, one of our senior professor, Dr. Mohan Kumar sir, was asking, Raji Malayali ano? Ado. Rupesh sir, you're muted.
Cherian, can you make Raji a co-host, Cherian? Raji, screen share നോക്കൂ. Raji, can you try?
Okay, sir. Post disabled participant screen sharing വരുന്നു.
ഒരു മിനിറ്റ് രാജി. Okay, try it, Raji.
Okay. Screen കാണാമോ sir?
Yeah. I started screen sharing. Screen sharing is in the company set. Maybe. Yes. Yes, Rajesh.
I couldn't. Okay, another.
Yes. We can.
Stop sharing ചെയ്യട്ടെ അപ്പൊ ഇപ്പം.
Stop sharing.
Okay. Headphone use ചെയ്യണോ sir? ഇത് okay ആണോ ശബ്ദം?
Yeah, Manju, can you hear? My internet is a little bit fickle.
That's what. എന്തൊക്കെ ചെറിയൊരു ലാഗ് ഉള്ളത് പോലെ തോന്നുന്നു സർ.
Lag is okay, but the voice is clear.
Voice is clear. Voice is clear.
ബാക്കി പാർട്ടിസിപ്പൻസ് ഒക്കെ യൂട്യൂബും ഫേസ്ബുക്കിൽ കൂടെ അല്ലേ ജോയിൻ ആവുന്നത്?
അതിന്റെ അകത്ത് നമുക്ക് 100 ലിമിറ്റ് ഉള്ളത്, ബാക്കി യൂട്യൂബ് വഴിയാണ്.
അതെ ഓക്കെ.
ഡോക്ടർ ചെറിയൻ ലോഗ് ഓഫ് ചെയ്ത് പോയി തോന്നുന്നു അല്ലേ? നിങ്ങളുണ്ടോ? ഇതൊക്കെ കാണുന്നില്ല ആണോ? ഇപ്പൊ ഞാൻ ഹോസ്റ്റ് ആയല്ലോ. ആണോ? Cherian, can you hear me? Cherian?
I'm here.
Okay.
Can you hear me?
Yes.
Okay. Yeah, I'm okay.
Yes. So in a couple of minutes, I think we should be ready to go.
Just that I had to change a laptop.
Okay. Right. Yeah, Cherian is very loud and clear. Manju, Mohan sir is promoting a rebase for you.
It's rebase 2022, no? It's not 23.
Yeah, 23. So, so our next rebase will be held at Amrita, and Dr. Manju is the organizing chairperson for the same. So Mohan sir has kindled the rebase thought.
That's what I was telling him. Raji, how about Radhika ma'am, Dr. Neelam, they all will be joining?
Ma'am, yes, they have said they'll be joining, but I think they'll be joining through the YouTube or Facebook link only. I did not share this link. I thought participants might be full here. So I thought everybody has to join from there. So they'll join from there.
Yeah, you can send them the link also. Looks like Sunday morning. The thing is that in our YouTube link, Raji, this will be playing on for ages. So
Okay, okay.
so the children already know that even if they don't log in on time, they can still
No,
watch. They can
there
still
were
watch.
some queries from people also whether we'll be getting a recorded version later also. So I thought, acha,
Yeah.
Sunday they don't want to do this. Maybe later they'll just go through it and see. So it's okay. So.
No, it'll be playing on our YouTube channel. So,
Ha.
Dr. Cherian, if you can record the proceedings from now on, it'll be good. Dr. Cherian, if you can record the proceedings. And shall we start? A very good morning to each and every one of you who have logged in this Sunday morning to the IPS Kerala Vet Talk series on this 21st of August 2022. My mathematics is a little bit wrong. I wrote 21. I'm still lagging behind. So apologies for the same. We have with us a very dynamic young speaker. Many of you know Dr. Rajalakshmi, as she was the scientific chairperson for the previously concluded national conference at Nagpur. And today we are extremely happy at the IPS Kerala State Branch to have Dr. Rajalakshmi as our speaker today. She is here with a very poetic kind of a romantic kind of a topic as well as prosthodontics is concerned. Romantic and poetic, I said, because today happens to be World Poets Day. So, so Raji, thank you for coming up with this particular topic. And to all the senior citizens who have logged in, my respected teacher, Mohan Kumar sir, my good friend Cherian, myself, and all the other, the senior person today. Today is National Senior Citizens Day too. So greetings to all of us from for being. Mohan sir didn't like me calling him a senior citizen. And
No problem. All the best from all of us to all of us.
So thank you everyone who have logged in. Many of us, I'm sure all of you have logged in on your YouTube, on our YouTube link, as well as I'm sure as the time progresses, a lot more of our postgraduates will be logging in. Kerala postgraduates have an exam coming up tomorrow, so probably a few of them will be busy preparing for it. But this we thought was a right topic on the eve of their postgraduate exams too. So welcome each and every one of you, and let me now invite our president, Dr. K.P. Cherian, to deliver the presidential address and welcome the gathering. Over to you, Dr. Cherian.
Thank you, Dr. Rupesh. Welcome and good morning all. It's indeed a great honor to be back again with our Web Talk series. I think this is the third of the year so far, and we've been promoting young and upcoming prosthodontists to our IPS Kerala has taken it on to promote such people. And this young lady here, Dr. Rajalakshmi, has been, I have not heard her personally, but I've heard lots about her, and I would like to hear what she has to say today, and hope it would be a benefit for us old foggies and all the young upcoming prosthodontists too, and for all prosthodontists in general. And yes, this video would be available on our YouTube channel forever. So there is no problem in that also. Thank you again for accepting our invitation and coming here, Dr. Rajalakshmi. And this session is going to be moderated by our good friend and very well-known person, Dr. Manju. Thank you, Manju, for accepting to be our moderator for today. Dr. Mohan Kumar, sir, thank you for being here early in the morning. Welcome all the participants so far. I think there are more on YouTube also. Welcome again. Good morning. Have a good day. Thank you.
Thank you, Dr. Cherian, for those very warm and welcoming words. I'm sure all of you can look forward to many such events from the IPS Kerala State Branch. Thank you, Dr. Cherian. And may I now proceed to welcome our moderator, like Dr. Cherian said, a very astute and well-known moderator. We're very fortunate to have Dr. Manju Vijay Mohan, who is a professor and head at Amrita School of Dentistry. I'm sure many of you know her. She's an acclaimed, astute, dedicated academician and researcher par excellence, having has a great interest in the fields of maxillofacial prosthodontics, dental implants, and more currently bone tissue engineering, in which Dr. Manju has just completed her PhD. So congratulations, Manju, for the tremendous work and research that you are doing in these fields of MFP and bone tissue engineering. Other than being the HOD, Manju has just taken over as the head of Department of Prosthodontics at the School of Dentistry. She's also an adjunct faculty at the UCLA in the USA, a very favorite student of the much renowned MFP teacher, Dr. John Bumer. So Manju is also an adjunct faculty at the UCLA. Dr. Manju, we are extremely happy and proud to have you as the moderator for this wonderful session of the IPS Kerala Web Talk series, and I hand over the proceedings to you, Dr. Manju. Over to you.
Thank you, sir. Thank you for your kind introduction. President Cherian sir, Secretary Rupesh sir, and all executive members, and all dear faculty and postgraduates who joined for this session, both in Zoom and YouTube. Actually, I'm really happy to introduce our young, multi-talented academician, Dr. Rajalakshmi Banerjee. Currently, she is working as an additional professor and postgraduate guide at Department of Prosthodontics, VSPM, Nagpur. She is the secretary of IPS Nagpur branch. She was the co-chairperson of 48th IPS National Conference at Nagpur. Still, I remember the conference you have conducted, the meticulous coordination of all the scientific sessions and all. So kudos to Dr. Radke ma'am, Dr. Neelam, Raji, and the entire team for that. And currently, she is the co-in-charge of the maxillofacial unit, Prayas, at VSPM Nagpur. And she has a teaching experience of 16 years. And she did her MDS from Bharati Vidyapith Dental College and Hospital, Pune. She's completed in 2006. Then about her awards, she has received many accolades. She has many accolades to her credit. She got first prize for scientific papers, posters, table clinic competitions at national level multiple times. Actually 15 or 16 times it's written here. She has nearly 34 publications to her credit. Then Dr. Rajalakshmi conducted several workshops and was invited faculty for various conferences at national level and state level. Then she has received she has awarded the Certificate of Appreciation by Indian Prosthodontic Society Head Office for contribution as Regional Branch Editor of IPS Nagpur Branch, Journal of Prosthetic Rehabilitation. So it goes on like that. Actually, my association with Dr. Rajalakshmi started long back when she came for a conference at Amrita. Then later I conducted a workshop at VSPM. So those who visited there know the amazing hospitality they provide, that KMM and the entire team. Thank you, Dr. Rajalakshmi, for accepting our invitation. Then before starting, we know tomorrow the Kerala University postgraduates exam will be started. So I'm sure this session will be definitely useful to them. Once again, thank you, Raji, for accepting our invitation. Over to you, Raji.
Thank you so much, ma'am. So, sir, should I start my screen sharing?
Yeah, before I invite Dr. Rajalakshmi, may I request all the participants as the lecture progresses, kindly post your questions to Dr. Manju through the chat box on the Zoom platform, as well as people who are watching on the YouTube channel, kindly post your questions to the speaker through the moderator on the comment box in the YouTube channel as well. So over to you, Raji. I request all the participants other than the speaker to kindly mute your microphones. Thank you. Over to you, Raji.
Yes, sir. So thank you so much for that wonderful opportunity and invitation to join the web series of IPS Kerala State Branch. I thank Dr. K.P. Cherian, sir, the president, Dr. Rupesh, my elder brother, Dr. Manju, the moderator for the session, Dr. Tony, Dr. Mohan, and all the other executive committee members of the branch. These are the two places that live in my heart, or my heart is in these two places, the Orange City, Nagpur, where I live and practice, and my own state, Kerala, where my heart belongs. So season's greetings. And before I start my presentation, let me wish all of you a very happy new year, as it was Chingam Onna, and in advance, happy Onam to all of you. So beginning with the topic that I'm supposed to speak about today is deprogramming. We'll be deliberating about why, when, and how to deprogram. Manju ma'am has introduced me very lovingly with so many adjectives. I humbly accept her love for me. Thank you so much, ma'am, for always being an inspiration and a support for me. So we'll be covering the lecture in all these parts. We'll be knowing about, not in details, but about centric relation. So what are muscle engrams, the pathophysiology of muscle dysfunction, what is deprogramming, when, how, and why to deprogram, how do we locate the centric relation position, the bimanual manipulation or palpation technique given by details about the working or pathophysiology of the muscular dysfunction and what an anterior deprogrammer does, types of different deprogrammers, duration for use of deprogrammers, caution when deprogrammers should not be used, a slight differentiation between deprogrammers and splints. So this is what the lecture is going to comprise about. Not in too much details. I'm not going to complicate the topic too much. I have tried to simplify it for the sake of the postgraduates as much as possible. Sir, am I audible properly?
Yes, Rajni.
Yes.
Okay, ma'am. Thank you. So no prosthodontist or no postgraduate of prosthodontics would debate or undermine the importance of centric relation, which we definitely believe that organization of occlusion at centric relation is very much essential for a stable and harmonious relation between the teeth, the muscles, and the temporomandibular joint. So in whole, the masticatory apparatus as a whole functions the best when it is settled or set at the centric relation position. Now, the definition will not go into the details, but as we all know, the centric relation is the jaw-to-jaw relation, independent of tooth contact. We know the condyles will articulate with the avascular, non-innervated portion of the articular disc, which is most capable to take up stress. Therefore, this is an unstrained position and repeatable reference position, which is not altered or changed by the presence of teeth. It can also be said that centric relation is the position where the jaw comes into the position where it can rotate along the terminal hinge axis position. So only rotatory movements are possible at the centric relation position. As soon as the jaw translates or opens beyond 20 millimeters, it goes into the translatory movement and does not remain in the centric relation position. So to have a centric relation position, it has to be along the terminal hinge axis. The condyles articulate with the articular disc in the glenoid fossa along the terminal hinge axis. Now, when this happens, all the loading forces are directed through, as we said, the avascular, non-innervated tissues of the interarticular disc, which is best suited or adapted to taking up of the stress without any discomfort. So it is least to say that centric relation is a position where the condyles are in the musculoskeletally stable position, and all the masticatory apparatus with the musculature, the teeth, and the temporomandibular joint are in their equilibrium or the best suited position to take up masticatory stresses. Recording the centric relation and mounting the cast in that position on the articulator also helps us to determine which are the occlusal interferences and thereby also helping us to do the occlusal equilibration. Now, all this is what is normal, but sometimes things go wrong and there is a bad interference or a bad habit that develops, which is called as a deviated muscle engram or a deviated muscle memory. Now, what is an engram? In simple terms, it is the conditionable reflex that the muscle develops, which is said to be a very short acting reflex which acts for less than 2 minutes. If for more than 2 minutes the muscle memory is lost, it forgets that particular engram. So by repeated use of the same position or the same movement of the jaws, the muscle gets adapted to a muscle engram, and that is the reason for this movement or the a changed or a deviated movement of the mandible. So what happens? Why does this happen? As Dawson has shown very clearly in his book, this is what a normal masticatory apparatus would look like with good occlusion, all the elevator depressor muscles and the masticatory apparatus with the temporomandibular joint in all its healthy stage, healthy condition. So you can see that condyles are articulating properly with the avascular portion of the intra-articular disc. But now what happens in the second picture? There is a interference. So especially when there are crowns given or some restorations which are placed high, or maybe some interference develops in the posterior region or posterior teeth, it leads to pain or tenderness in the tooth with the interference plus hyperactivity of the masticatory apparatus. So the muscles become hyperactive, which leads to incoordinated and hyperactive spasms in the muscles, which lead to or prevent functioning of the coordinated musculature with a coordinated pattern of contraction and elevation, the release of the opposing muscles. So when this is affected, there is the muscle spasm or muscle tenderness, which create the muscle engram, which will allow or which tries to avoid the point of contact, which creates the interference, and that leads to the deviated jaw closing. So now, as we said, what happens to the muscles after this interference comes up? The muscle changes the jaw position to avoid or escape the interfering contacts, and this particular deviated closure becomes memorized in the muscle memory as an engram. So this is what is a muscle engram. So once an engram is fixed, in many cases that come to the department, we see there are reasons for adhesion of teeth, maybe anterior adhesion with less amount of posterior adhesion. And what can be the reason? So sometimes it comes to a deviated closure of the mandible, maybe to protect or to avoid the posterior interferences. So now comes the role of deprogramming. So deprogramming is nothing but breaking of the muscle engram by using a device which is called as a deprogrammer. So this deprogrammer allows the patient to close into the musculoskeletally stable position, that is the centric relation position, without interference from these posterior teeth or the musculature trying to deviate the mandible. This is the basic meaning of deprogramming. Means what has been set, it has to be broken and you have to go back to the normal musculoskeletally stable position. So something like this, with the introduction of an anterior plane, a plate, the mandibular anteriors are contacting with the flat plane and the posterior interference is eliminated, allowing the muscles to relax and thereby placing the condyles into the centric relation position. So this is the basic goal of the deprogramming device, to remove the to eliminate the interfering contacts and to help the condyles to seat into the centric relation position. Now, why do we do a deprogramming? The three basic objectives are the first, as we said, to record a proper centric relation. For this to happen, it is necessary sometimes to break the muscle engram, to break the muscle memory, which may have developed into a deviated closure and into a habitual different position as compared to the centric relation position. Another third very important objective of deprogramming is to differentiate between the intracapsular temporomandibular joint disorders and muscular disorders. We'll come to the details of this later as we go on. Now, how do we decide which patient is okay for deprogramming? So we have to do something called as a load test first, where we check that there is no tenderness of the joint. Then there are no other signs or symptoms of instability in the joint. And if there is a positive finding during the muscle palpation, if you have checked, you palpate the muscles, the pterygoids, masseters, or the temporalis, and you feel that there is positive finding, that means a tenderness or some pain in the joints, that means the muscles are hyperactive and in contraction or in spasm. So in such cases, it is necessary or it is good to deprogram. Now, for locating the centric relation position, there are two different methods described in literature, the chin point guidance technique and the bilateral manipulation technique given by Dawson. So the chin point guidance technique is easy, but again, it slightly tends to push the mandible slightly more posterior to the centric relation position. Dawson's bilateral manipulation position or technique is found to be better in terms of positioning the mandible in its centric relation position. So as we said about the load test. Now in load test, it is important to use the bimanual manipulation or bimanual palpation. So while doing this, using the bimanual manipulation technique, the joint is loaded first under light pressure, then this is proceeded to medium and then firm pressure. And then you have to ask the patient whether there is any pain or tenderness felt in the joint. So here I'll be demonstrating how to do the load test and the bimanual palpation. Please let me know if the audio is there with the video, or else I'll speak along with the video. Is the audio there?
Yes, Raji. You can hear?
Audio, it's not.
Audio is not there?
No.
Yeah, Raji, you can speak again.
Okay. So here I am going to demonstrate how to do the bimanual palpation as well as the load testing. You can see the position of the patient and how I am seated behind the patient. The chin has to be placed a little towards the upside. The patient should be relaxed. The dentist has to be relaxed with upright positioning, feet firmly touching the ground, resting on the ground. And your shoulders, the wrist, everything has to be relaxed so that you do not put your pressure onto the mandible while recording the centric relation position. So as we start, you can see that the index fingers are kept along the lower border of the mandible with the smallest finger just below or behind the angle of the mandible. All the fingers are kept close together. The thumbs are placed on the symphysis region. You have to see how the C is formed of the thumb with the rest of the fingers. So this is the position for the bimanual manipulation. Take care you do not push the mandible or distalize the mandible into centric relation. You have to just do a doorknob rotation type of movement for proper location of the condyles into the glenoid fossa. Now you can see that there is a cotton roll that is acting like a deprogrammer kept between the anterior teeth. Posterior teeth are completely out of occlusion. Now you have to tell the patient as soon as the cotton roll is removed, the deprogrammer is removed, no teeth should come into contact. As soon as the deprogrammer is removed, teeth should not come into contact. So now just see that the mandible is free. Just do the small rotatory movement just to free the elevator muscles of the mandible. Slowly start applying pressure and ask the patient to tell which is the first point of contact when the mandible is closing. So the patient is showing left posterior region as the first point of contact. Again, repeat the same procedure. Relax only rotatory movements and similarly asking the patient again for the first point of contact. So maybe that is the area or point which is the interference. So we are also coming to know which point is coming into contact first. So again, repeating the same procedure. So the patient tells me it is the left posterior tooth which is contacting. And you can see that reprogramming has been achieved. And now you are proceeding for the load test. So I am applying pressure now. Light pressure first. Slightly more. And then lastly, firm pressure. As I can see that the patient is comfortable, I'm asking the patient, confirming whether there is any pain, any tenderness in the joint, and she says that there is no pain. That means the load test is negative. So the patient has no problem with the load test. The joint is healthy. That means there is no intracapsular pathology. So whatever the problem is occlusal. So I can record that first point of contact that is causing the interference, and then I can record the centric relation, transfer it to the articulator, and can remove that interference by occlusal equilibration, and then that would be my treatment. So was that video clear?
Yes, Rajlakshmi.
Okay, ma'am. So that was explaining about how to proceed with the bimanual palpation and the recording of the load test and checking whether it is an intracapsular pathology or it is an occlusal pathology. So now with the patient here, I could make out that it was a left lateral, left posterior tooth that was creating the interference, and the any TMD related to intracapsular pathology was absent. Now, what are the common errors that happen during bimanual palpation is trying to force while applying pressure. As I said, you have to be relaxed. The jaws have to be completely relaxed and in the rotatory position before starting to apply pressure. So no force has to be applied. It has to be a small rotatory door knob type of a movement to just rotate the condyles into position. So trying to force the mandible into centric relation too early before the muscles have relaxed, that is one problem that happens, and less firm pressure for seating the mandible. So fearing that there might be pain or something, so less firm pressure is if it is applied. So that is also a most common error. Other errors can be positioning problems, incorrect doctor and patient positioning. Placing the fingers all over the entire mandible. So this is the method, positioning of the fingers that has to be followed for a proper positioning of the condyles into the glenoid fossa. And jiggling the mandible. Sometimes with less confidence with students doing it, they tend to shiver or maybe jiggle the mandible before placing it into the centric relation position. So that will also create hyperactivity in the muscles. The muscles don't relax, they don't deprogram, and therefore you will not get a proper centric relation. So it is important to note that patient should be guided and not forced into centric relation. So basically, what does an anterior deprogrammer do? This anterior stop acts as a fulcrum. It disengages and disoccludes the posterior teeth. It releases the hyperactive contracted muscles, which then become relaxed. And therefore, these elevator muscles, which are now relaxed, will have directional forces which seat the condyles. They direct the condyles into the most stable, that is superior anterior position, the centric relation position. Now, the same thing, what we achieve with bimanual palpation, where the condyles are seated into the superior deprogrammer, when the anterior contact the condyles in the glenoid fossa, positioning them into the superior anterior position, that is the centration position. Now, according to Friesmeier et al., occlusal appliances can be classified into 3 groups. Group 1 are the reflex appliances, like the NTI, Dawson's B-splint, or the Coy's deprogrammer. The group 2, which is stabilization appliances, like the stabilization splint or the Michigan type splint. And group 3,
it looks like Dr. Rajalakshmi's internet is down. We'll just give a couple of minutes for her to rejoin.
Okay, sir.
Yeah, welcome back, Raji.
Yes, sir. So I think I was lost in between.
Yeah, internet.
So I'll start sharing again. Yeah. I'm so sorry for that. Sir, is this where it was gone, or should I take a little back?
I think this was where you group 1, group 2, and group 3. Yeah.
So, as we were talking, deprogrammers come in group 1, which are the reflex appliances. The splints, which are meant for therapeutic purposes, come in where the mandible, the basic purpose is to place the mandible in a particular position, are the group 2 and group 3 appliances. So occlusal appliances can be classified into group 1, group 2, and group 3. And as we said, anterior deprogrammers are characterized or categorized in the group 1 of the classification. So different types of anterior deprogrammers can be the simple cotton rolls, which we very commonly use in clinics. For better deprogramming and for proper evaluation, it should be a leaf gauge that should be used, or now very commonly we use Lucia jig, the nociceptive trigeminal inhibition or tension suppression system, NTI-TSS, Cranham deprogrammers, Dawson's B-splint deprogrammers, Coy's deprogrammers, and mini deprogrammers. So cotton rolls, as we said, just a simple cotton roll kept in the anterior teeth with taking care that posteriors are disoccluding. There are no teeth posterior coming into contact. This kept for 15 to 20 minutes in mild contraction of the muscles can also achieve good deprogramming. Can be very easily done in a clinical setup. The second is use of leaf gauge. Leaf gauge is nothing but 10 leaves of PSA plastics, which are 0.01 inch thick, 0.05 inch wide, and 2 inches long. There's a hole which is punched, and you can see a bunch of leaf gauges like that, and you can just slightly go on reducing till there are no contacts seen, and then record the centric relation. Lucia jig, again, a very commonly used method by postgraduates for deprogramming and to record.
I think Dr. Rajalakshmi has lost a connection again. Please hold on.
Yeah, looks
Back,
like.
sir. I don't know why this is happening.
Yeah, I think from tomorrow onwards, the 5G connections are going on. So, Raji, probably the central government is
I
jinxed.
have to, sir. I'm so sorry, sir. Is it okay, sir?
Yeah.
Okay. So, coming to Lucia Jig, again, a very commonly used deprogrammer by the postgraduate students. It is very easy to fabricate, and for recording the centric relation position, mainly in full mouth rehabilitation cases and all, postgraduates are using this technique. So this is nothing but a device called resin, which is adapted to the maxillary incisors with an occlusal stop for the mandibular incisors, and then an interocclusal check bite or a bite recording material can be record the centric relation. So here I'll be again showing the method of fabricating the Lucia jig and the method of adjusting the Lucia jig. It is a very common method, but I propose that
All these breaks will help the postgraduates to recollect and rethink what has been spoken so far. Okay.
so I'll just change my connection just a minute.
Sure, sure.
So is this okay?
Yeah, I think it looks fine. Let's see. Play the video.
Okay, so here I am going to demonstrate how to prepare a Lucia jig and to adjust the Lucia jig. Now on this, you can see on the articulator, I have raised the incisal pin so as to have some gap between the posterior teeth, especially 2 to 3 millimeters between the 2 to 3 millimeters between the premolar region, and taking care that there are no posterior teeth which are in contact. Check properly. This was the point that she was saying that there is an interference. Again, on the other side, check that there are no interfering contacts in the posterior region. You can also see that we have also blocked out the interdental area so that while removing the acrylic deprogrammer, the teeth don't break. So now we start marking till where we want the extension of the deprogrammer, 2 to 3 millimeters above the gingival margin. That is till where we need the deprogrammer to extend, taking care that the frenum is not hampered or the frenum is relieved. Again, 3 to 5 millimeters on the palatal portion of the incisors is still where the lingual portion of the deprogrammer will extend till. So this is how we mark. Now apply a tinfoil substitute or separating medium judiciously. So that it becomes easy for us to remove the Lucia jig after it is fabricated. So we start mixing now. Cold cure acrylic resin. So mix it till it is properly homogeneously mixed. You can see. And now after we achieve it enters the dough stage, the initial dough stage, it is taken into the hand, kneaded properly. Mold it into a small ball, adapt it onto the incisor surface. Posteriorly on the palatal surface, it is given a triangular shape with a bite plate in the palatal surface of the incisors. Cut out the excess. You can see how the cutting of the excess is done. It has to be kept triangular towards the palatal surface with a biting surface for the mandibular. Slightly angulated. So on the labial aspect also, the excess is cut away. You can close and see if there are any indentations. You have to make it a flat plane. So you'll have to reduce all the indentations and make it a flat plane. Now this is the jig that was prepared after it's set, finished and polished. Now we are going to try it in the patient's mouth. So that is the platform, the labial surface. Okay, just place it in the patient's mouth. So you see for the fit, there should not be any rocking of the jig. The platform is straight. You ask the patient to close and check there are posterior disocclusion. There's no contact. It is extending only till the central incisors. Now you ask the patient to close and see whether there is posterior disocclusion achieved. Okay, if that is there, you might have to add a little to the jig. So we are checking if there is no contact. So it is only the anteriors that are come in contact. No other teeth are coming into any contact. Now this is still where we all do, but now we need to adjust it so that there is a single point centric relation contact before we start with the centric relation record. So now what I'm trying to do is I'm trying to see if there is a single point contact or there is any other interfering contact. So I'll place it and I'll ask the patient to do a right lateral, left lateral protrusive movement, trying to get something like a needle house tracing. So the patient is moving the jaw to check for any other point contacts other than the centric contact that has to be removed. So now this is what I've achieved. These are the contacts which are interfering other than the centric relation contact. So what I need is a small 3 millimeter point that is the centric relation point before I record the centric relation with the Lucia jig. So this 3 millimeter centric relation point is what I want. Rest of it should be trimmed off. So this is how we start trimming away of all the other contacting regions other than the centric relation point. So we need that, if we can see that darkly marked center 3 millimeter point is what we want to be remaining on the jig, and all the other contacting points have to be removed so that there is no interference while recording the centric relation. So now we check again. So now we place the articulating paper again and ask the patient to do all the required movements similar to what we were doing. Okay, so ask and guide the patient to do all the movements. So this is what we have again got. It will require some more amount of trimming. You can see one side wing is gone, but the other side is still there. You also can see that 3 mm small circle in between, which has to be maintained. So that wing has to be reduced, and then we will have the properly adjusted Lucia jig to have the recording of the centric relation. So now again we do the same thing. So now we have achieved the single point contact with the 3 mm circle. All the other interfering contacts have been removed. So now this point should be in contact. This is the centric relation point contact. We place the jig again, place the patient, ask the patient to close, and this point contacting the mandibular incisal edges would be giving us the centric relation. Now the interocclusal bite record can be placed and a record can be made from using this Lucia jig. I think I was clear with the video of preparation, making, fabricating the Lucia jig and adjusting the Lucia jig in the patient's mouth so as to make it most effective for recording the centric relation. The other deprogrammers that are used is the NTI-TSS, nociceptive trigeminal inhibition tension suppression system, mostly used for temporal and occlusomuscle headaches and facial pain. These are also readily available in the markets, but it is nothing but a deprogrammer, which other medical practitioners also prescribe, saying that it relieves facial pain and migraines and occlusomuscle headaches, but it is nothing but a deprogrammer that just relaxes the muscles and therefore relieves the pain. Cranham deprogrammer with a palatal plate extension, and this is given overnight, and this commonly is used for occlusal equilibration procedures. Coming to the next type of deprogrammer, that is the Coy's deprogrammer, very commonly used by private clinicians nowadays, given for overnight use. The patient comes back the next day to the practice, and then immediately after removing the deprogrammer, the centric bite is recorded. This is Dawson's B splint. It is also called as a splint because you can see that there is a plate covering the occlusal surfaces of all the teeth and a small palatal ramp on the anteriors for deprogramming. Mini deprogrammer, just a small extension. The posteriors are kept free or relieved without the deprogrammer. Only anteriors are placed. This is with a deprogrammer. This is also used as a night guard to relax the muscles and in cases of bruxism. The other uses of anterior deprogrammers, other than recording the centric relation, is to prevent bruxism. Also, as with we have seen with Dawson's B splint, where it is also a splint, so all the occlusal surfaces are also covered. And when posteriors do not come into contact, that also helps in prevention of bruxism. Occlusal trauma, as we saw, tension type headaches like NTI, TSS, deprogrammers are used for treating tension type headaches and migraine. Though we know how and when to use a deprogrammer, it is also a word of caution to know when not to use a deprogrammer, especially when in the load test we come to know that there is an intracapsular pathology. That means the patient complains of pain after application of pressure in the load test. In such cases, you should not go for a deprogrammer because that can worsen the situation. When there is chronic anterior disc displacement, seating of condyles with a deprogrammer can change or progress a reducing click to a non-reducing click. If there is a lateral pole click, intermittent clicks, or patients in whom recently developed reducing pole clicks, lateral pole clicks have developed, in such patients also, deprogrammers should not be used. Even with medial pole displacements, there will be significant pain if a deprogrammer is used and pressure is applied on the retrodiscal tissues. So especially when there is a TMD pathology, intracapsular pathology, a deprogrammer should not be used. And how will you confirm that? By the load test. So proper application of the load test and determining whether the pathology is neuromuscular or intracapsular is very important to judiciously use a deprogrammer. Now, time required evidence in literature says varied time intervals. Maybe it also depends on the type of spasm or the type of hyperactive contraction that the muscles are in. So in some patients, 15 to 20 minutes, 30 minutes is good enough. Some patients might require an hour-long deprogramming. A good practice nowadays in clinical practice is give a COIS deprogrammer, let the patient go home, use the deprogrammer as soon as the next day the patient comes, but that is without the deprogrammer kept out of the mouth, even for a minute. So it has to be completely deprogrammed for 24 hours. As soon as the deprogrammer is removed, the centric relation has to be recorded without the teeth coming into contact. And in some patients with severe muscle spasms, few days to weeks might also be required. But again, here it is very important to note that long-term use of deprogrammers is not required or should not be done because it might lead to supraeruption of posterior teeth. As with deprogrammers, it is only the anterior tooth which is coming into contact. Posteriors are free to supraerupt. So longer duration use of a deprogrammer should not be usually done. So there is always a confusion in postgraduates about deprogramming and splinting. It is totally different. The basic purpose is different. Deprogrammers are used to break the muscle engram. That is the purpose of deprogramming. Whereas splints are the devices which are used to position the mandible in a particular position. So when we saw about the occlusal appliances, there is group 1, group 2, and group 3. Deprogrammers are group 1 and splints are group 2 and group 3. So deprogrammers cover only the anteriors and worn for very less amount of time just for recording the centric relation. If it is, as we already said, if it is used for a longer duration, it can lead to supraeruption. Whereas splints cover the whole dentition and therefore are also used for longer duration as compared to deprogrammers. And there is no risk of supraeruption because all the surfaces of teeth are covered at least by maintaining a single point contact. So some evidence or some studies, so Ramachandran et al., they assessed clinical symptoms and condylar positions of TMD patients using CBCT imaging with a deprogramming splint therapy. And they saw that there is occlusal equilibration showed reduction in clinical symptoms. That is a clear effectiveness of the deprogramming with mild changes, minor changes in the condylar position also. So this study stated that the deprogrammer splint therapy is very effective in showing reduction in the clinical symptoms like pain and tenderness in the muscles. Now, James McKee compared the bimanual palpation technique to the deprogrammer using centric relations recorded using a bimanual palpation technique of dorsal, and the other method was using a deprogrammer. So he said there is clinically significant similarities between both the techniques. They could achieve the same centric relation using both the techniques. So using deprogrammers was as effective as doing a bimanual palpation. Kinderneck et al. Showed the effectiveness of a deprogrammer on the position of the terminal horizontal axis, and they said that there is less than 0.5 millimeter difference in placing of the centric relation position with using of a deprogrammer for 12 hours. Again, now COIS deprogrammer, in a study that Gaikwad et al. Did for checking the efficacy of different deprogrammers, it was found that Coy's deprogrammer was the most effective, and it created the very good results in masseter and temporalis muscles involving both sides, and it was confirmed to be very effective in achieving patient-centric relation position. Recent advances in deprogramming include the transcutaneous electric nerve stimulation, where the muscles are relaxed by giving electrical stimulus, and then bite registration, the neuromuscular bite registration of the centric relation position. Again, a new appliance has come, which is called as an equalizer. It is nothing but a gel type of liquid filled into the pads, which are placed buccally and labially. As the patient closes into this movable or very gummy sort of a pad, it relaxes the muscles, and then after removing this, immediately centric relation can be recorded. So summarizing, we can say that it is a very useful, a valuable diagnostic tool to first differentiate whether any TMD is an intracapsular pathology or it is a neuromuscular pain that is there. Also, while recording centric relations, where a devious or a deviated muscle movements have been there, or a habitual position has been adapted by the patient because of interferences, in such patients, using deprogrammer is a very good method before recording centric relation. So all postgraduates should make it a habit to just check whether the patient is giving a coinciding centric relation before recording the centric relation position. It should be a diagnostic tool. While as you record the case history, this should also be a thing that you do deprogram and check for the centric relation. That will clear many doubts, and it will make the treatment plan very easy. That is what I think. So this is some useful literature for the postgraduates if you want to read more into deprogrammers. So concluding, I'll say what COVID times have taught us is to never give up. Like the IPS Kerala branch, which has come up with such innovative methods to keep up with digital web talks and so many online events that happen continuously. It is hats off to the IPS State branch. And Rupesh sir is always very innovative in all his things that he does. So thank you so much, Manju ma'am, Rupesh sir, Cherian sir, for giving me this golden opportunity to present whatever little I know about the topic. I think it might be helpful for the postgraduate students. And as you said, it is university exams coming up. I offer my best wishes to all the postgraduates. Thank you so much, sir. Thank you so much, ma'am.
Thank you. Thank you, Dr. Raji. It was a wonderful session. You have clearly explained all the entire details of TMJ, the muscle dysfunction, then the various engrams, deprogramming, the various types of spleen, everything you have covered well. Thank you.
Thank you so much.
For this 100% useful for the postgraduates, for the practicing clinicians and all. Thank you. In chat box, I think only one question.
So there's somebody who's asking what is the difference between a Coy's deprogrammer and the anterior bite plane. So if you know orthodontic bite planes, the basic purpose is to achieve posterior eruption. In cases of deep bite correction is the bite plane used. Whereas the purpose of Coy's deprogrammer is not that. It is to deprogram the muscles so that we have the centric relation position. So the basic purpose of both these appliances itself is different.
Period of use also it may vary, no?
Yes. For correction of deep bite, it is going to use a longer duration of time till the posteriors erupt, they come into occlusion, and then that deep bite is relieved. So the use, the purpose, the treatment duration, everything is different.
Yeah,
Please
Raji.
post your questions in chat box. Answer.
Yes, sir.
Yeah, I think quite a few people have asked questions on the YouTube channel.
Okay.
One of the questions is, ma'am, how long should the deprogrammer be kept in place before the bimanual palpation and load maneuver is done? That is from Dr. Reshma Raju.
So, Dr. Reshma, what I understand from your question is for how long the deprogrammer should be placed before you start with bimanual palpation. Isn't it?
Yes.
So, a cotton roll or a deprogrammer for about 10 minutes should be enough without any posterior contact to start with bimanual palpation.
Okay, Reshma is again continue to ask Raji, in case there is an absence of anterior teeth, how do you deprogram in case a patient has an absence of anterior?
Absence of anterior teeth.
Correct. Yes.
Okay. So, in cases where there are no anterior teeth present, any appliance that can disocclude the posterior, if you make a small prosthesis for the anterior and then disocclude, or a bite plane which is thick enough to cover the whole ridge as well as to disocclude the posterior. Obtaining disocclusion of the posterior is the objective. Even if the anteriors are not present, you can slightly keep some block which will provide that amount of space so that there is posterior disocclusion.
Raji, can you mention how much interocclusal clearance has to be given?
Ma'am, in the bicuspid region, it is 2 to 3 millimeters. Yes. For the molars, maybe it has to be out of contact, 1 millimeter, 0.5 millimeter, anything is possible, but in no movement, in the lateral movements also, it should come into contact. There should not be any contact in any point of movement.
So I think canine, we can take as a important.
Yes, yes.
Raji, Dr. Divakar Santanam. Dr. Divakar Santanam, he has asked, how do we confirm whether deprogramming is done if bilateral missing of molar teeth, no patient has missing molar teeth, and if only premolars are present? And how do we confirm whether the patient has undergone deprogramming?
Sir, after deprogramming, when we try to close into centric, there will not be any problem in closing into centric. And again, load test can be used to check whether the centric has been achieved. If the centric relation is proper, while applying the firm pressure also, there will not be any pain. But if the mandible is placed anterior or you are pushing it more posterior, there will be pain in the joint. So load test can be one method of being sure that you are directly on the avascular uninnervated portion of the interarticular disc while closing.
Repeatedly, we are getting the same position.
Same position, repeatable reference, same point and no pain should be a good check method for that.
Okay.
My very good friend, Dr. Devi Prasad Mukherjee, I'm sure you heard of him. He has complimented you that, it's been a very clear presentation on the centric.
Thank you so much, sir.
He also asked, there are few deprogrammers used for increasing the VD.
So those are not deprogrammers actually. Those are a type of splints that are used because there is continuous contact on all the teeth. It is like a bite tracing appliance where in the form of like where full mouth rehabilitations, we try to check if there can be slight raise when there is a class 3 type of full mouth rehabilitation case where there is no space. So that is not a deprogrammer actually. It is a sort of a splint where we are trying to gain some or encroach upon the freeway space slightly.
Correct.
Okay, our TMJ expert, Dr. Mohan Kumar sir.
Yes, sir. We'll like to.
A few questions are there. Are you sure that mandible can ever make pure rotation? How do you know when the first question is that, are you sure that mandible can ever make pure rotation?
Ma'am, that is what literature says. Till about 10 to 15 millimeters of movement, it is inside the glenoid fossa around the hinge axis, which produces rotatory movement. After we open more than that, it translates and comes into protrusion.
Sir? Sir, are you there?
Mohan sir. Mohan sir was not happy with my answer, I think.
Yeah, sir. Yeah.
No, maybe what? Hello, sir. Maybe what? what sir was probably asking is during that rotation movement, during that period, whether it is pure rotation or it is 100%.
I think sir has joined back.
Sir has joined. Yes, sir.
The first question is answered. Sir, please unmute, sir. Please unmute. Still
Mohan
muted.
sir, you are muted.
Cherian, can you unmute, sir? Mohan, sir. We can only request.
Sir, can you hear us?
I can only ask.
Correct. Anyway, we can. I think you can
go on.
The second question is, how do you know when the muscles are deprogrammed?
I had asked about. I asked a few questions. Muted.
So now we can hear.
Muted.
Sir, your first question is answered. So is it enough? Are you satisfied with the answer?
I can hear you.
It's breaking, sir. Your voice is breaking. Third question is, and why is it that if deprogram is used, then why does a reducing disk become non-reducing? Question, is it clear, Raji?
Yes, ma'am. Yes, ma'am. Because what we were saying is the condyles will be placed, or it might be pushed into placement into the glenoid fossa. So the articular disc which is there and the condyles come and sit over it. With a reducing click, it is normally moving along the borders of the interarticular disc and going back into the glenoid fossa. But when we deprogram, it comes down, and when it goes back into the glenoid fossa, this articular disc is pushed forwards, and it becomes the non-reducing click. So in cases where there is an actual intracapsular pathology, deprogramming should not be done. That is what literature says. Because there is always a risk that that disc would become pushed into the anterior portion.
No, my question is,
yes, sir.
Why does the anterior deprogrammer cause a reducing click to become a non-reducing click? That was the question.
Yes, sir.
Because you are holding the mandible forward. I mean, when you bite on an anterior, your deprogrammer, actually the mandible is brought a little forward. It has to come down to get the bite, right? And then why is it causing? I mean, then the reducing click should be reducing click. Why does it become a non-reducing one?
So the article which is mentioning this is saying that the articular disc might get pushed anteriorly and become a non-reducing click because of the deprogrammer. As it rotates, the mandible posteriorly.
Why is the disc moving anteriorly? What's the disc got? You are moving why is the disc moving anteriorly, and why is it getting non-reducing? I mean,
so because posteriors forward, are without, because only anterior teeth are contacting. So there is a rotatory movement of the condyle into the glenoid fossa.
But okay, fine. But are you sure that the mandible? No, are you sure that the mandible can execute pure rotation inside the fossa, in centric? Is it true now? Is it true nowadays?
Nowadays there is a little there is a little contradiction to this statement, but we believe that in that glenoid fossa there should be rotatory movement.
Okay. Sorry to
no, sir. It is a pleasure.
Okay, the third point. The third point is, how do you know? You have put the anterior deprogramming. That's a question that has been troubling me for some time. You put an anterior deprogramming and you gave some time limits, like somebody says 15 minutes, somebody says 24 hours. Fair enough, no problem.
Yes, sir.
But then how as a clinician do you know that the muscles are deprogrammed? Which muscles are deprogrammed? Which are the muscles that are deprogrammed when you put this anterior, this deprogrammer? Which are the muscles? And how do you know they're deprogrammed? But wait, when you bite on your deprogrammer, the lateral pterygoid is active. And then how do you know that the masseter and temporalis are deprogrammed? Is there anything in literature telling us how the clinician can judge? Okay, now the muscles are deprogrammed. I don't know.
Judging, sir, maybe.
I have no idea.
The loss of muscle tenderness, the pain subsides, and the load test. I think load test should be one thing that should tell us that the centric
Load-
relation is achieved properly with placement of the condyles in the proper position.
lab. But then, but then the lateral pterygoid is still active, no? So lateral pterygoid is not being deprogrammed. Is that it? Is lateral pterygoid is not deprogrammed? And then my question is, when you're clenching on, when you're not clenching, sorry, when you're biting on this particular deprogrammer, and which is not always true, because then you keep the mouth open. There's a previous page business. Okay, whenever that happens, how do the muscles get relaxed? Because obviously it's biting or in contact with the deprogrammer, no? So how can the muscle be relaxed?
The posterior teeth are not coming into contact with the deprogrammer. That happens with a splint. A splint has a single point contact, but deprogrammer, there is no contact posteriorly.
Agreed. But how do you know that the muscles are relaxed? Because the muscles are active. They are pressing against your deprogram. Your means the deprogrammer. And how do they mess it? I mean, do you have, is there any literature telling whether they have checked the EMG of the muscles before and after?
Yes, sir. There are literatures where EMG activity of muscles have been, like one article that had shown, they checked with EMG activity.
No, not EMG activity. I'm talking about muscles.
Muscles, EMG of the muscles, electromyography study of the muscles. EMG.
But before, I mean, to show that when you put this deprogram, the muscles
have relaxed. Yes, sir.
But any particular, I don't know, any particular reason they have not mentioned, I guess. I don't know. So that is, the clinician has just to put it in the mouth and then okay, fine. Then one more small little thing. You mentioned that the whole basis of this Dawson's technique. Dawson,
yes, sir.
The book is a little old, 2006. That doesn't matter.
Yes,
the point is, what is the evidence today to show that occlusal interferences are the cause for it is a muscular origin of TMD?
That is not there, sir. Now, the recent evidence says that occlusal interferences are not the reason for TMD. But here we are not talking about that. We are just saying that deprogramming will help us to get centric relation and to differentiate between intracapsular pathology and muscular pathology. If it is just a muscular pain or a muscular spasm, neuromuscular origin pain, or it is an intracapsular pathology.
But then you mentioned something about the first tooth contact or something, no? You mentioned that you found that
when we are saying that interfering contact may be causing the muscle engram.
That's what I'm saying. So that means, again, we are back to the whole same story, that occlusal interferences are the cause of muscle problems. And I'm asking, I don't know, because that is what they've been. If you identify the interference, then you told, I think you can do occlusal some correction there to reduce the problem. So
yes, sir. What they are saying is, in the occlusal equilibration procedure, getting that first point contact is necessary to remove that interference so that mandible can easily close into centric relation position. So if that interference is the reason of the deviated closure, that should be removed to help the condyles to get seated into the glenoid fossa in the centric relation position.
But you're fine. That is fair enough. But then, so that means it is not the cause of the muscular problems.
No, it is not the cause. It is the cause of the muscle engram that is changing the centric relation position.
So fine, that is the argument. Then okay, maybe that is true, but it's not for the correcting the TMJ, the muscle related.
No, sir. Problem. For that, splints are required. Other therapeutic splints, even splints now it is contradicted. There are other. There's another theory coming up where the gut, the digestive system.
I think the people. I'm sorry, sir.
Sorry. Please continue.
No. The problem is that among the prosthodontists, because of the confusion among the prosthodontists regarding the veracity of all this, I think our oral medicine friends have stepped in and are making a lot of money using splints as their mode of therapy, which I am dead against. And I don't know whether it's a phenomenon throughout India or whether it started in the south and moving towards the north. So anyway, Thank you, sir, for the question.
Yeah,
I think it's all very valid, but the problem is that there is nothing. I don't think there is anything hard and fast about rule or right about what is right in TMJ or what we can diagnose and how we can treat it and all that. It's all very subjective, and I mean that's my take on it. I don't know.
Yeah.
Rajlakshmi.
Again, Dr. Mohan Kumar sir has stirred a lot of other students have also raised a few questions. If Manju can.
yes, sir. Thank you, Mohan Kumar sir, for your input.
Enough. Thank you. Sorry, I took too much time.
Actually, Sri Lakshmi from Amrita, she is asking, ma'am, are there any specific indications for use of different deprogrammers, or is it the choice of the clinician?
It is
You said-
basically the purpose of all deprogrammers remain the same. It is experience and expertise of the clinician using one deprogrammer or over the other. As I said, in recent private practices, COIS deprogrammer has become very popular. Initially, when we were doing our post-graduation, Lucia Jig, we always preferred Lucia Jig to record centric relations. So it depends on what you are comfortable with. The basic purpose is to achieve deprogramming with whatever device you feel is good enough for that is fine.
Yeah, whether you want to
Sri
customize.
Lakshmi, your queries answer.
I think there is one question from Amrita Matthew. Can you see Amrita Matthew? She's asked, Madam, kindly explain how to identify the first point of contact. From Amrita.
Yes, Amrita. So like in the patient, in the video that I had shown, I was asking the patient, now she was my postgraduate student, a prosthodontic postgraduate student. So she might be more familiar to tell me as to which is her first point of contact, which maybe a patient may not be able to say, but still, if you guide the patient well to not have any contact, and then when they are closing, just to identify which area that contact is happening, they'll be able to say that. If it is the anterior, definitely you can see that there is not an anterior contact that is happening. It has to be a posterior first. Right or left, they'll be at least be able to tell you the area. So at least you know which is the area that is first coming into contact, and maybe is an interference if that is preventing from going into the mandible to be held into the centric position. So that is how you record it. Or you can use, after you ask the patient to close and have the first contact, just record that, make a bite record, place it onto the articulator, and then you'll be able to make out which is that point.
Yeah, Raji, thank you. And I'm sure Amrita's query is answered. A few more questions from our YouTube link. Dr. Divakar has again asked, Madam, when you use a cotton roll for deprogramming, the interocclusal record should be made for the complete arch or no?
Of
Because
course.
in Lucia Jig, we used to make interocclusal for the posterior teeth only.
Ah.
So it is for the full arch, isn't it?
Yes.
For the full arch, yeah. And Monica, I think your question, Raji, is already answered. Whether the anterior teeth, when anterior teeth are missing, what can we do? There is another question from Dr. Manasa Murlu. Madam, if the load test is positive, we cannot go ahead with the deprogramming.
No.
So then in that case, how do we go ahead with the treatment?
Then we have to go for intracapsular pathology is present. If that is being suggested, we have to go for the TMD correction, because maybe like we are saying splint stabilization or repositioning splints, or any other management of the temporomandibular joint, but not to deprogram in such a case. First treatment of the TMD and then the rest.
Dr. Mishra, Madam, if there is a supra eruption of the last molar, both on the contralateral and the opposite, occluding teeth, if it is absent, then how much of clearance we need to require? And if there is a supra eruption, how do we get that clearance?
There has to be a gap. There has to be a gap. So like we said, and in the premolar region, we have to achieve 2 to 3 millimeters, taking care that no posteriors are touching. So if it is required that the posteriors have to be disoccluded, maybe in the premolar we have more space. So a jig that would be big enough or long enough to create that amount of disocclusion as required.
Yeah. So Dr. Meher has also asked a similar question. I'm sure Raji's answer would have answered your query, Dr. Meher. Dr. Amanpreet Kaur, she is just now asked, how can we judge muscle engram has been cured in 20-25 minutes? I think you already said, Dr. Mohan Kumar sir, Amanpreet, how can we judge if the engram has been cured in 20-25 minutes? How do we judge?
Sir, the engram has been broken. That is what she's saying.
Yeah, how do we know whether the engram has been cured or meaning broken in 20 minutes?
So engram is nothing but what they are saying, it is a conditional or it is a reflex which has a memory of less than 2 millimeters is what is being proved now. So mandible kept out of occlusion for more than 2 minutes will give you deprogramming. That is what is being suggested. So here we are talking about 10 minutes, 15 minutes, half an hour.
Right.
So according to literature, definitely the muscle engram is not going to stay for that long. It is just a conditionable reflex or a memory that is in the muscles to close the mandible in such a way that the contact, the interfering contact is avoided.
Correct. Yeah, very well answered. We'll take one more question. I think later Dr. Raji will go to YouTube and you can probably look into these questions and reply to them personally.
Yes, sir, no problem.
Dr. Divakar, we'll take one last question and then we'll conclude. She's asked what is the choice the patient to remove it for taking food.
That is one this thing where we ask the patients to wear it overnight. We are giving it to the patient for 24 hours wear. Patient cooperation is very, very important. If the patient is removing it, then we can say that the deprogramming is back to its normal and then again it starts deprogramming. So when the patient comes to the clinic, at least we can be sure that when we remove the deprogrammer, the centric is recorded immediately. But the patient has to be aware and educated as to not to remove the deprogrammer for the whole day. Or else the other thing that clinicians do is ask the patient to come 1 hour before, keep the deprogrammer in mouth for an hour and then make the record.
And Dr. Shaila Dureja has just asked, using this Lucia jig, do you still keep it in the mouth while taking the bite or you remove it?
So that is one thing, like with Lucia jigs, we make separate sectional bites. The Lucia jig in place and interocclusal method, the material is placed. If you're removing the Lucia jig, take care before recording, before placing or the patient biting onto the bite record, the biting material, the recording material, the teeth should not come into contact. So the main objective is deprogrammer out of the mouth, immediately centric relation has to be recorded with the biting material, interocclusal bite material.
I'm sure, Dr. Shaila, your query has been answered. I think she's asked a couple of things more. Dr. Raji, you can go to our YouTube channel and directly. I'm sure a lot more questions will be coming through.
Yeah, a few more questions here. Again, Mohan Kumar sir is asking, but won't the wearing of the deprogram create new engrams?
New engrams, we are talking about breaking of that muscle engram, which was deviated and not allowing the mandible to close into centric. So here, now what we are saying is with the help of a deprogrammer, the muscles, because there is posterior disocclusion, the muscles are relaxed. So they are in their tonic equilibrium position. They are relaxed and they are not creating any more contraction. It is in a relaxed state. And in this relaxed state, when the recording is done, it goes into centric record or centric relation position.
Hope your query is answered.
Ma'am, I can share my mail ID also if later anybody wants to.
Yeah, many questions are there.
Any more questions? Yeah.
Raji can post it on your on the YouTube channel also, so that people can.
Yes, sir. Yes, I can.
Yes. So, Raji, from the questions you have generated, your talk has generated, it speaks volumes.
I'm happy people are actually thinking, and I thought initially that deprogramming, a very small topic, mostly now postgraduates overlook it, just directly go for centric relation recording without thinking about the muscle engrams or deprogramming. So good that at least that thought has been triggered.
Yeah,
Yes.
especially for full mouth rehabilitation cases,
Yes,
Sandra, it's 100% useful.
Yes,
So
ma'am.
thank you, Raji, for this
Thank you
informative
so much,
session.
ma'am. Thank you, ma'am, for moderating it so wonderfully and being my support always.
Not only for postgraduates, for clinicians also, it's really useful. Thank you. It's like a music we were hearing. We are seeing the video, everything together. It's really an amazing
you.
session. Actually,
Yeah.
deprogramming the topic is a dry one, but you have explained very nicely, very clearly, have conveyed the message clearly to everyone.
Yeah.
Thank you, ma'am.
As a mark of our love and respect and gratitude, may I request our President, Dr. Cherian, to hand you over this particular certificate of appreciation. We will see that a hard copy also comes to you at some point in time. May I
Thank you
request
so much, sir.
Yeah,
Dr.
so
Cherian to-
Rajlakshmi, please accept this certificate on behalf of Indian Prosthodontic Society, Kerala State Branch. For
Thank
the
you, sir.
wonderful session. Thank you.
Thank you so much, sir. Thank you.
And Manju for being an excellent moderator. Our deepest appreciation to you. May I request Mohan Kumar sir, sir, kindly hand over the certificate to Dr. Manju. Sir, are you there? Mohan sir.
Sure. I think he's left.
Okay.
Yeah,
Dr.
Shyam Mohan, if you want.
Shyam, make a comment. Shyam, do make a
Shyam
comment.
has been silent all today. Yeah, now we see him.
Yeah, Dr. Shyam was the one who wanted to know who Dr. Rajalakshmi is.
I've seen her live.
Yes, Dr. Rajalakshmi, it was really informative. I think you touched all the basics, I feel.
Yes,
So,
sir.
very informative for the postgraduates, I feel, So this is one topic not touched by many.
Yes, sir.
You have addressed those areas. I think the postgraduates should go back and read on this, You got a curtain raiser. Now you have to
Yes,
take
sir.
it.
So Shyam, please hand over the certificate to Dr. Manju for being an able moderator.
Yes, always. It's a pleasure. Manju,
Thank you. Thank you. Thank you, Dr. Shyam. Thank you so
from
much.
my screen to your screen.
And,
Thank you.
thank you.
And let me, on behalf of the IPS Kerala State Branch, thank Dr. Rajalakshmi once again, and to Dr. Manju for initiating, and bringing in this topic to us, and getting Dr. Rajalakshmi here. Dr. Manju, thank you so much for this very thought-provoking morning session what we had. I'm sure all the postgraduates, especially those who are going for exams tomorrow. If I am the examiner somewhere, I'm definitely going to ask some questions on what Raji has spoken. I'm sure Cherian has also taken some notes.
He's just announcing that he's the examiner of one college.
So thank you so very much, and being നമ്മളുടെ മലയാളി കുട്ടി ആയ
Sure.
എല്ലാവിധ ഓണം
You're
ആശംസകളും
from God's own country.
Yeah.
Yes, yes. എല്ലാവർക്കും തിരുവോണം ആശംസകൾ in
Yeah.
advance.
Same to you.
Same to you, Raji.
Hopefully we'll have one debate on this, something similar to this at a later stage. And have a wonderful day, wonderful Sunday lunch, and thank you so much. Till,
And best wishes to all the exam going students.
Yeah.
Yes, yes, ma'am.
I think, as a president, Dr. Cherian, I think you should pass on a best wishes message to all the postgraduates.
Yeah. On so to all the KUHS candidates preparing for the practical exams tomorrow, all the best from the Indian Prosthodontic Society Kerala State Branch. Thank you.
Thank you, and have a great day. Thank you, Raji, once again, and bye-bye. Regards to all at home. Thank
So
you.
much.
Thank you, Rajalakshmi.
Thank you.
Bye, bye, ma'am.
you, sir.
Bye. Good
Thank
day.
you.